Good to see you. I came because that you will be coming. I didn't know that you're going to do an online. So good friend. So at the outset, I really thank Thiranjan Basu for inviting us. And I came mainly because to meet a lot of our friends. Good to see a lot of our friends. So probably 5 to 8 minutes, because everybody has already covered what is required. And now I'll be going to the more practical aspects and our experience. So there's already touched. So any patients, especially the lung cancer and triple negative breast cancer, please make sure that they are evaluated, especially for brain metastasis. Brain metastasis should not be considered as one of the detrimental as a prognostic factor. Now we are looking for 85 to 90% local control with the help of Sbrts. And definitely we should make sure that it is treated in a proper way. So incidence goes, the lung becomes the first one, like it, breast and lung and GI tumors are the most common. If you see overall, cerebral hemisphere is one of the main things what we are looking at. Isolated, like we are talking about the hippocampal sparing. So there is a selection criteria for that. We have to make sure within 2 centimeters there is no metastatic lesions. Isolated hippocampal metastasis is very, very rare. Probably like I've seen only 1 or 2 cases where like the nearby, but isolated are very less. So brainstem, eloquent areas, all this has to be taken into criteria for whenever you are treating, making a decision. Symptoms versus asymptomatic, this is a very controversial. So especially nowadays, now with the newer trials coming up, this is like it's entirely depends on you how you're going to treat. MRI is a gold standard. We are aware of that, but you should be very careful. PET CT scan should be a part of your planning for like ruling out the other areas. Definitely PET based increasing the SUVs is going to make a difference. So treatment options, radiation, surgery, supportive care with dexamethasone is another one. And targeted agents is already talked about. Asymptomatic patients wait and watch for up to 1 to 2 years, even if it is a progressive lesions. If it is asymptomatic, there is trials which says that you can continue TKIs. So treatment decision factors, we've already talked. Site and size of the size makes a lot of difference in terms of degree of mass effect and edema. Functional status, we know we are already dealt about this. So favorable prognosis and poor prognosis becomes a very, very borderline. Like in terms of decision making, everybody should go through these 2 articles, treatment for brain mets, ASCO guidelines and ASTRO guidelines. So the limited brain disease, if you see ECOG, most of the times ECOG also depends on your patient symptoms. If there's a single lesion with an eloquent area, if there is ECOG goes down, it falls into the other group. You should be very careful about that. And I definitely prefer that the patient condition and the systemic disease control is one of the things which makes me to take a further decision. If you have a good surgical approach, neurosurgeons one, if you see the size of the lesions here where they're talking about, initially it was 3 centimeters. Now we are talking about 2 to 4 centimeters. Number from 4 lesions, it has come to 5 to 10 lesions. So it is a moving target, and definitely we have improved. What is important to know is proportionate of microscopic disease in the other parts of the brain is probably the one which is making a clinical decision here, and availability of the resources. Extensive brain metastasis, all the like we have an option of stereotactic radiosurgery, fractionated stereotactic radiosurgery, whole brain, hippocampal sparing with neurocognitive functions to be taken into care. So surgical approach, yes, if it's a symptomatic, easily approachable, neurosurgeons, it has to go inside and remove as much as possible. And I feel that sometimes if you are giving same options without the surgery, you should go for the non-surgical approach. And because complications of surgery is also delays for the treatment. Radiotherapy, yes, we talked about hippocampal avoidance, whole brain RT, 30 gray in 10 fractions. It is not, if it is not there, nothing to worry. 30 gray in 10 fractions becomes like a blanket treatment. But as much as possible, you can definitely increase the dose to that. For a microscopic disease, it is definitely better. For the gross disease with the different histology, it makes a difference. Probably dose escalation locally it dictates the overall survival and local control. SRS, I'm not a SRS guy. I don't practice single fraction right, anywhere in the body. I prefer 5 fractions, 3 or 5 fractions. Even if it is less than 2 centimeter, I've given 10 into 3, 30 gray in 3 fractions to the primary, the smaller area less than 2 centimeters single rather than a single fraction. Because there's an history, because when we are in AIMS, we have seen like many patients coming for the follow-up whenever giving a single fractions with the central necrosis symptoms related, the patient's treatment related symptoms were more. So probably the local single fractions may increase the like central necrosis. Fractionated SRS 10 to 35 gray, 2 to 5 fractions. I'll tell you why I'm putting 2 gray as one of the boost and 5 fractions. I've given 7 into 5 also, the 35 gray, depending on the histology. Like simple example, a CA lung presenting with a single lesion. So I prefer to give a 7 into 5 with a radical approach to both the areas. Complications, we know that the edema is actually not really the one what I'm looking at. Central necrosis causing the edema is one thing which is, and all other factors we are already talked about that. There is a lot of things which is coming up to avoid these things. Probably the stereotactic, the fractionated SRS makes a lot of difference in taking care of the symptoms. The edema is less post-treatment according to me in these patients. We are already talked about memantine and the neurocognitive. For yes, when you are talking about SRS, we now move to a more than one lesion, the multiple sites SRS, especially in the brain. So now we are talking about up to 10 lesions. Like I've done only 10 lesions for Sbrt. More than 10, no, I have not done FSRS. So we have the different machines. CyberNet scores over all of these things, even if it is a lung or in case of brain, because multiple sites, stereotactic radiosurgery, like fractionated, will definitely easy, or like we can tackle it in a better way. So I don't want to show this. Coming to our experience, that is where the practical, we talked about theory, everybody showed the different one. So I have reached almost around, we have reached around 5,000 patients. My contribution is almost around 4,000. Lung, it's 411 patients. And bone metastasis, around 500 patients now, and primarily the breast. The lung is second one, around 136. So lung with the different one, so we have around 192 patients. Brain metastasis is around 92, and lung metastasis from a different area is 148. How we do is like we are all know about that complete neurocognitive and brain lab is important, especially in the brain metastasis. All lung cancer should go for biopsy, IHC, and genomics, because driver mutated, the mutations, the treatment is definitely entirely changing. PET CT is absolutely important. I insist that at least for first year, once in 3 to 4 months, give a PET CT, get a PET CT based treatment. It definitely is going to make a difference. MRI, I told you that like as a screening, make sure that any lung patients before going to the particular treatment should get an MRI, and also the triple negative breast cancer. And MDT decision is important, follow-up is important. So what is you're seeing that the different lesions, so multiple brain metastasis, fractionated. So 1 to 5 lesions is the one what I still go for, like fractionated 5 fractions SRS. Less than 5 centimeters, everybody told it's 4 centimeters. I'm practicing since long time, 5 centimeters is the cutoff. And the more than 5 centimeter chances of microscopic disease in the other places will be more. Supra or infratentorial lesions, as nobody has told, that is, I feel that anywhere in the supra and infratentorial suppression also makes a difference. If it is one area, either supra or infra, more than 3, then you should go for, if it is less than 3 lesions, you can still go for the fractionated. 25 to 30 gray. Re-radiation setting, there's no doubt that we had to go for SRS, fractionated SRS. Post-op cavity, we're already dealt with. And especially in post-op cavity, you can, if it is a cerebellar lesion, posterior fossa, do only Sbrt to the lower, the posterior fossa. And if it is a multiple lesions in the supratentorial area, we can give whole brain to that. So that's some of the things we are doing it. In case of more than 5 lesions, whole brain RT followed by boost is the one. If you are not, if you don't have the SRS like stereotactic facility, at least do a simultaneous integrated boost. 40 gray in 10 fraction to the primary and whole brain 30 gray in 10 fractions, other sequentially. This is more of a practical approach. Definitely you will see a better difference. I'll take 2 minutes. So this is one of the things what we need. Immunotherapy followed by Sbrt combinations we have done. Day one immunotherapy followed by the Sbrt. Some of the cases like, do you know, and as much as possible, please treat the primary tumor in all these cases where brain mets are there. And this is one patient where lung presented with the brain metastasis. So responds very well. She's still alive and doing fine without any problem. So another whole brain followed by the big lesions more than 5 centimeters, followed by the 2 fractions of cyberknife. And radionecrosis is one of the things. Steroids may not be a very good idea to continue for a long time. I use bevacizumab as an anti-edema for these patients if the necrosis is more and its edema is going to be. So the time duration, in case of presentation, if it is a metastasis, I prefer to give higher doses and complete this one. If there is a duration is more than 2 years, then if the numbers are less than 5, we can directly do. This is another patient where CA lung treated in 2010. After 2 years, he developed a small brain metastasis, and there was no metastasis elsewhere, and continued. And all this, most of the times there is a metastasis occurs. If there is a recurrence, dural mets are more common rather than the isolated mets. There's a post-operative treatment. The primary, the patient presented to the neurosurgeon, operated, and I've treated the primary and the post-op cavity and the supratentorial lesions as well. And the follow-up is also doing well. Immunoradiotherapy, yes, it is the in thing. Definitely we can consider for both the areas, the primary and the metastatic disease. Is one of the cases, first cases where we are given whole brain followed by Sbrt and immunotherapy combination. So fantastic responses without treatment related. So we have small presentation done and presented last Astro. This is 3 years back. And we've seen that Sbrt alone and Sbrt with ISBT. And we've seen the most of this oligometastatic trial, brain mets was a suppression, like exclusion criteria. We've seen that almost there's a definite advantage of Sbrt versus non-Sbrt. And with immuno-Sbrt, we see that 5 months survival extra, and also mean overall survival is almost around 11 months extra. And immune profiling is another thing we have to look into. So to conclude, the Sbrt or SRS is effective in brain mets. Local control is at the range of 85 to 90%. Definitely, we should not say that it should be considered as a palliative treatment all the time. Hippocampal sparing should be like tried as much as possible and followed by SRS. If it is not there, at least consider for simultaneous integrated boost. Post-op SRS is absolutely fine. Dose should be range of 12 to 35 gray. Sbrt to the primary in any of this brain metastasis, please consider the primary Sbrt in the same setting. It becomes more viable, and combination of immunotherapy is going to make a difference. Thank you, my team, and your patient hearing.
Thank you, Dr. Sridhar. I now invite Dr. Vinita